Hello, everyone, and welcome to this Embark ERS Lessons in Bronchiectasis webinar. I'm Michal Steinberg. I'm a pulmonologist from Haifa, Israel, interested in bronchiectasis and adult CF. And this webinar series is a project of Embark, the European Bronchiectasis Collaboration, and intended for everyone with an interest to learn more about bronchiectasis care. Today's topic is inflammation in bronchiectasis, and it will be presented by Dr. Emma Johnson and discussed by Amelia Shoemark. Both are from Dundee, Scotland. And before I hand over, some housekeeping notes. Please be interactive. Either use the chat option or speak up to place questions and comment. You mute your microphones and camera unless you want to speak. Use the raise hand option if you wish to do so, and we'll call the name that appears on your participant screen. So please make sure it's the right name. And translations are available. So if you see in the slide, you can use the captions option at the bottom of the screen. And if you are using a translation, please be sure to drop us a comment and about the translation quality, indicating the target language. So with this, I'm really happy to hand over to Professor Amelia Shoemark, a researcher from the Respiratory Research Center in Dundee University and a member of Embark Management. So hi, Amelia.
Hi, thanks very much, Michal. So yeah, this session is on inflammation in bronchiectasis. I think it's a really important topic here. The first discussion of the pathophysiology of bronchiectasis was Peter Cole's vicious cycle, and that described inflammation. A two-edged sword was the title of that paper. So we've known for a long time that inflammation is important in bronchiectasis. And yet a lot of the treatments and things that are available all focus on the infectant aspect of the disease. So I'm really excited to hear Emma's cases today on inflammation in bronchiectasis, and hopefully be able to have a good discussion about treatments and also the pathology behind inflammation in bronchiectasis. So Emma works in Dundee with me and is an excellent PhD student here, as well as a medic. And I'll hand over to you now, Emma, for the presentation.
Thanks very much. So as Amelia said, I am a PhD student and I'm doctor in Dundee, and I'll be talking today about inflammation in bronchiectasis centred around 3 case presentations. So I'll start off by heading straight into the first case. Case 1 was a 78-year-old lady who had pneumonia at the age of 15 and subsequently was diagnosed with bronchiectasis at the age of 19. She had been very stable clinically. She developed recurrent Pseudomonas aeruginosa in her sputum in 2013, but actually had no symptoms associated with this, so it was not treated. She also had gastroesophageal reflux, a history of breast cancer, and she had no occupational or environmental exposures. She had started a prophylactic clarithromycin back in the 1990s and continued on this as it was controlling her symptoms very well. She was on a steroid inhaler due to a historical diagnosis of asthma, but again had carried it on, and then just some other medications for her comorbidities. She presented in 2020, having had 2 recent hospital admissions in both 2019 and 2020, with a worsening of her respiratory symptoms, cough, purulent sputum, extremely breathless, and both times was treated with 2 weeks of oral ciprofloxacin, and was commenced on Naxus and chest physiotherapy. But despite this, she continued to have chronic purulent sputum, a cough and breathlessness on a daily basis after her hospital admissions. And in terms of investigations, she continued to grow Pseudomonas aeruginosa throughout this time. In March 2020, she had a culture which was resistant to ciprofloxacin, but then in July 2020 had one that was sensitive to ciprofloxacin. Her pulmonary function test showed obstructive pulmonary function, and her bloods showed a persistently raised CRP, which fluctuated between probably around 50 and 140 over the course of the time period. Other than that, she had normal bloods, including normal aspergillus, serology, immunoglobulins, etc. And this is her CT scan. It showed widespread varicose bronchiectasis throughout both lungs, with relative sparing of the lung bases. There was also some bronchial wall thickening throughout the lungs as well. So in terms of next steps for managing this lady with chronic Pseudomonas infection and chronic symptoms, I'd be interested to know everyone's thoughts on whether you would advise admission for 2 weeks of intravenous antibiotics, maybe a switch from a prophylactic antibiotic from clarithromycin to azithromycin, perhaps a nebulized antibiotic, or simply switching her inhaler away from a steroid inhaler.
So we don't have formal polling today, so if anyone would just either write in the chat or just speak up, unmute and speak up and say what you would do. Obviously, this is a really difficult case, and while Emma was showing the CT, I noted the how very malnourished she was. So she almost has no chest wall thickness, which is really extraordinary.
Silence from the chat.
Yeah.
Emma, do you want to take us through a little bit of the rationale behind each of the four options? I said, do you want to take us through a little bit of the rationale behind each of the four options?
Well, I suppose intravenous antibiotics are, we know that the Pseudomonas was sensitive to intravenous options. And she's very symptomatic and unwell, so an admission for intravenous antibiotics could be a good option. Azithromycin is recommended in bronchiectasis. We know it has immunomodulatory effects in addition to its antibiotic effects, and it's usually prescribed now rather than clarithromycin. Nebulized colamycin is also recommended according to guidelines, and then she doesn't have eosinophilia. She doesn't have any symptoms of asthma, so perhaps a LABA/LAMA inhaler. Would you like me to carry on to what we ended up doing for her, or do you want
we have someone saying in the chat that inhaled, I think it's inhaled anti-pseudomonal antibiotics when she's stable, and now she does need IV.
Yeah, so we have a vote for IV antibiotics. Yeah, do you want to go ahead, Emma, and show us what you did?
Well, yes. Well, actually, this was a difficult case, and actually all of the options were trialed at some point. So firstly, we opted for a nebulized antibiotic, which initially did result in a reduction in her symptoms, but she then developed wheeze. So severe wheeze when taking the nebulizer, so we had to stop it due to that side effect. She was then trialed on nebulized ceftazidime as an alternative nebulized antibiotic, but this again caused side effects. After which she did not want any further nebulized antibiotics. She felt she'd tried them and just didn't enjoy the side effects. So she was switched to prophylactic azithromycin, which again had some impact on her symptoms, but did not completely cure them. And so ultimately, she ended up, as was suggested, being admitted for intravenous gentamicin and aztreonam, which did improve her symptoms. She, I think there were several months between her 2 admissions for intravenous antibiotics, but her symptoms did eventually recur. But that's most recently what we've been treating her with.
Reflectively, would you go straight for the intravenous antibiotics in a future case, or?
I would know. Well, me personally, I would trial the nebulized antibiotic, but I don't know if anyone else has any thoughts on what they would.
I think that's what I would have done. I think that's what I would have done. I would have brought her in. We don't have any evidence that this is the right thing to do, but that you have so little other options, you would probably want to optimize her IV antibiotics, although we probably will not be able to eradicate Pseudomonas at this stage.
I'll just move on to speak a bit about the rationale, the evidence underlying what we did. So the rationale behind the nebulized antibiotics was that the European Respiratory Society guidelines recommend a nebulized antibiotic for patients with bronchiectasis and chronic Pseudomonas infection. They also recommend macrolides in patients for whom inhaled antibiotic is not tolerated or not sufficiently effective. And this is backed up by some evidence. For example, there are a randomized study of 122 patients with bronchiectasis and Pseudomonas aeruginosa who found that patients who were adhered to treatment with a nebulized colamycin had reduced exacerbations over time compared to controls. Similarly, a recent meta-analysis, including 341 patients over 3 randomized control trials, showed that long-term macrolides reduced exacerbations in patients with bronchiectasis and Pseudomonas. However, as Amelia mentioned, antibiotics are the mainstay of patients with bronchiectasis and bronchiectasis with infection, but are they the only option, and will they continue to be the only option? Also, I think it's interesting that azithromycin does not exert antibiotic effect against Pseudomonas, yet does reduce exacerbations. So to sort of answer these questions about bronchiectasis, exploring the role of inflammation and particularly dysregulated neutrophilic inflammation, which is a key component in the vicious vortex, could sort of shed further light on future treatment options and current treatment options. So just to give some background about neutrophilic inflammation, in health, neutrophils contribute to the immune response primarily by phagocytosing bacteria, we know that in bronchiectasis their function becomes dysregulated, leading to increased use of other defense mechanisms, including degranulation and production of neutrophil extracellular traps. And neutrophil elastase, which is produced by activated neutrophils, degrades bacterial cell walls to fight bacteria, but also results in collateral damage to respiratory epithelium. And we know that neutrophil elastase is associated with disease severity in bronchiectasis and also with overall mortality. Similarly, neutrophil extracellular traps contain are webs of DNA containing many inflammatory mediators, including neutrophil elastase, and they disarm and trap pathogens. But in addition to this, they also cause damage to the respiratory epithelium, and their inflammatory proteins in nets contribute to an ongoing cycle of dysregulated progressive neutrophilic inflammation. And similarly, nets have been shown in the sputum have been shown to be associated with more severe disease in bronchiectasis and with reduced overall survival in bronchiectasis. And nets and neutrophil elastase are particularly interested in when we're looking at the relationship between infection with Pseudomonas aeruginosa and neutrophilic inflammation. Pseudomonas colonization is associated more than other bacteria with active neutrophilic inflammation in the airways. For example, a multi-center study conducted across Europe by Kier et al. Showed that sputum nets are much higher in patients with Pseudomonas than they are in patients infected with other bacteria. And similarly, Oriano and colleagues showed that sputum neutrophil elastase increases according to the relative abundance of Pseudomonas. And then going on to antibiotic response, the same study, multi-center study by Kier et al. Looked into response to systemic antibiotics in patients with Pseudomonas aeruginosa and other bacteria. And they found that systemic antibiotics for respiratory exacerbations were less effective at reducing sputum nets and time to first exacerbations in patients positive for Pseudomonas aeruginosa than patients positive for other bacteria. And then on the other hand, they found that long-term macrolide therapy given for a year did effectively reduce sputum nets in patients with Pseudomonas aeruginosa. So this is interesting because perhaps the effect of macrolides on exacerbations is, rather than being due to antibacterial effects, is due to its reduction in neutrophilic inflammation. And this is really exciting as the role of, as we're beginning to look into anti-inflammatory therapies for bronchiectasis. Multiple anti-inflammatory therapies targeting specifically neutrophilic inflammation have been tried. So CXCR2 antagonists, which target neutrophil recruitment in the airways, have been tried. Similarly, leukotriene B4 receptor antagonists, which reduce neutrophil chemotaxis, have been tried, and also treatments directly targeting neutrophil elastase have been trialled in bronchiectasis with the aim of reducing neutrophilic inflammation. However, none of them have shown a sustained improvement in quality of life and improvement in symptoms. However, more recently, treatments called the DPP1 inhibitors have been developed, which target neutrophil maturation in the bone marrow and block the development of neutrophil proteases, meaning that when neutrophils are released into the airways, they are unable to produce active neutrophil elastase and other proteases produced in nets. And they have been shown, the DPP1 inhibitor bronchiectasis in the WILLOW trial was shown to reduce sputum neutrophil elastase in patients with bronchiectasis, and was also shown to reduce exacerbations over time. So this is a really exciting time for bronchiectasis and inflammation, where increasing understanding of inflammation in bronchiectasis is leading to treatments that are directly targeting the inflammatory component of the disease. And given the links between particularly Pseudomonas aeruginosa and active neutrophilic inflammation, it would be really interesting to see whether these anti-inflammatory treatments are also effective in patients with Pseudomonas. So that concludes my first case. My conclusions were that Pseudomonas aeruginosa as a bronchiectasis endotype strongly associated with dysregulated neutrophilic inflammation. While first-line treatment is antibiotic therapy, nebulized versus oral, acute versus long-term, there is a potential future role for anti-inflammatory therapies targeting neutrophilic inflammation, which could counter antibiotic resistance in this patient group with co-infection.
Thanks, Emma. I think that's a really interesting case, and it's a really interesting analysis of the biology behind bronchiectasis and potential treatments. Do you think sort of DPP1 inhibition and targeting nets, do you think that will end up working for everybody with bronchiectasis, or do you think we're going to end up with a group of patients who benefit versus a group of patients who don't benefit? I mean, I don't know the answer, I'm just
Well, I think my understanding is 80% of bronchiectasis patients do have a neutrophilic inflammatory endotype, so it's potentially beneficial for all those patients. I think it's interesting, just related to Pseudomonas, I think where we previously thought, oh, it's to do with patients who have a predominant neutrophilic endotype, but maybe less so in infection, but I think this, the relationship with Pseudomonas shows that patients with infections, particularly Pseudomonas, could also potentially benefit. I'd be interested in everyone else's thoughts.
It's sort of a chicken and an egg, isn't it? Which comes first, the infection or the inflammation, and what's probably we need to treat both in order to get things back in control again.
Yeah, I'd like to point out a group of people with bronchiectasis that have been excluded from clinical trials, which are people with immune deficiency. And these are not included in the trial. The logic is not to create sort of a second hit or further compromise their immune system. And it would be really interested to see if people that receive anti-inflammatory therapies for example, for rheumatoid arthritis and they have bronchiectasis could also benefit from DPP1 inhibition, or people with immune deficiency, primary immune deficiency, humoral immunodeficiency, if that is an option for them, or is that a whole different endotype?
Mm-hmm. That's a relatively large size group of patients as well, isn't it?
Mm-hmm.
Anyone got any comments in the chat? Thoughts about targeting neutrophilic inflammation? I think there's a comment there. Can you speak of emerging evidence on the use of azithromycin in those with chronic Pseudomonas as well as Mycobacterium is already on inhaled as Trianem? Mikhail?
Yes.
Well, of course, before we start azithromycin, we have to make sure that there's not an NTM infection that we've overlooked. So we wouldn't want to give monotherapy for NTM with azithromycin. But saying that, there have been several works, especially in CF, that long-term macrolide can maybe even prevent infection with NTM. So before starting azithromycin, you have to take cultures, you have to take sputum cultures for NTM, but as long as you're sure that there's no NTM infection, I think it's probably beneficial. We don't know how long it's safe to give macrolides, but we just don't have that evidence. But it seems that that it is safe as long as you don't have NTM infection.
Do you want to carry on with the next case, Emma? Because I know you've got
Yep.
3 to get through.
No, I think. Okay, so the second case is a 72-year-old lady with a past medical history of ulcerative colitis, diagnosed in 1974. She had a pan-proctocolectomy and ileostomy formation in 1983, subsequently had a perianal fistula conservatively managed, but her disease was her ulcerative colitis was subsequently very quiescent. She was not on any maintenance medication at all for this. Only other comorbidities were hypothyroidism. She had never smoked, had no other occupational or environmental exposures, and was not on any other medications apart from levothyroxine. She initially presented in 2008 to the respiratory service with recurrent lower respiratory tract infections and a chronic cough productive of green mucus. She had multiple sputum cultures which were negative and had a HRCT chest, which showed bronchial wall thickening in the right lower lobe, but no overt bronchiectasis. So she was diagnosed with chronic bronchial sepsis and commenced azithromycin prophylaxis. He then remained stable for several years, was discharged from clinic 4 years later, and then stopped azithromycin 2 years after that, and remained stable until 2016, when her symptoms recurred. She had chronic purulent sputum, she was struggling to expectorate, and antibiotic courses with clarithromycin and doxycycline were having no effect on her symptoms. She didn't have any other systemic symptoms, but her respiratory symptoms were very distressing for her. She had pulmonary function tests done, which showed extremely good lung function. Multiple sputum cultures were again negative, including negative for tuberculosis and NTM. And her bloods were all very normal, with normal inflammatory markers, including eosinophils, and normal aspergillus serology, functional antibodies, and immunoglobulins. And this was her follow-up CT scan, which showed that the area of bronchial wall thickening in the right lower lobe had progressed into overt bronchiectasis with active inflammatory changes, including bronchial wall thickening, mucus plugging, and ground glass changes. So again, I'd be interested to hear your thoughts on the next steps for this lady. Would you resume her azithromycin prophylaxis? Would you focus on chest clearance with mucolytics and chest physiotherapy? Proceed directly to bronchoscopy with bronchoalveolar lavage to seek infecting pathogens? Or would you consider an inhaled corticosteroid?
Thanks, Emma. So while people are having a think and maybe writing in the chat about which option they might take, I'm curious about the stopping of the azithromycin prophylaxis. How regular is that happens, that you would stop azithromycin once somebody's on it?
Well, it is quite free. In my clinical experience, it's quite frequent that patients stop their azithromycin or do a trial of stopping their azithromycin prophylaxis if they've been stable for a prolonged period of time. I'd be interested in other people's thoughts. I don't know the guidelines on this, but usually it's a decision between the patient and clinician in our hospital.
And there's obviously good evidence of using inhaled corticosteroid for inflammatory or steroid for inflammatory bowel disease to reduce the inflammation. I'll never forget the first lady that I met that had bronchiectasis following a colectomy, because she was absolutely devastated by it, because nobody had warned her that could be a consequence. And one thing's sorted and it moves to the inflammation affecting another area of your body. And yeah, I think possibly these patients behave quite differently to some of the other patients that are seen in the clinic, and should probably be managed differently. I don't know, Mikhail, what your experience is and what you would do in this situation.
Yeah, I just wanted to say that we had some comments in the chat. We have some C, which is people voting for bronchoscopy with bowel and resuming azithromycin, and then Mattia, I see that wants to exclude NTM, which obviously I agree. Personally, I would try to get sputum samples and then go for inhaled corticosteroids. That would be my next option after getting the samples.
Great. Emma, do you want to tell us what you did?
Yes. Well, so I think this is interesting. Again, this patient had multiple of these options over the course of the next little while. Initially, she was resumed on azithromycin, started carbocisteine, and was referred for chest physiotherapy, but this did not impact on her symptoms. So she was commenced on an inhaled corticosteroid, given the evidence base for corticosteroid in inflammatory bowel disease associated bronchiectasis. But again, I think this had some effect on her symptoms, but she continued to have chronic sputum and infective exacerbations. And so they did, and then subsequently her CT, which was repeated, showed that she had developed a right lower lobe collapse. And so at that point, bronchoscopy was carried out, which showed purulent mucus throughout the lungs with very inflamed underlying mucosa and collapse of the lobe due to mucus plugging. The bowel showed was negative for NTM, but showed that she had Haemophilus influenza. So subsequently, so then she was treated with a course of antibiotics, a prolonged course of antibiotics to attempt to eradicate the Haemophilus influenza. She was commenced on a hypertonic saline nebulizer, but actually, as of now, her right lower lobe remains collapsed, and so there's ongoing discussions around how to treat her next. So unfortunately, I can't give you a conclusion. Multiple treatment options have been tried. And then to move on a bit to talk about inflammatory bowel disease associated bronchiectasis, which this lady had. It affects 18 to 26% of patients with inflammatory bowel disease. It's more common in ulcerative colitis, as this lady had, and more common in females. And again, similar in this lady's case, it often develops months to years after the initial presentation of inflammatory bowel disease. And interestingly, often after colectomy for the bowel disease. And then just a little bit about the pathophysiology. Both the lungs and the gut develop from the same region of the developing embryo, and both are composed of similar epithelium and columnar epithelium and goblet cells, meaning they are structurally very similar. So this is posited as one possible explanation for the link between inflammatory bowel disease and bronchiectasis. A second explanation for the link is that, as with bronchiectasis, neutrophilic inflammation is implicated in inflammatory bowel disease pathophysiology. And here the evidence base is less strong in inflammatory bowel disease, but you can see in this on the left, this was actually a mouse study, but it showed that epithelial cells from so the gut produced a lot more, or were characterized by a lot higher activity of neutrophil elastase in patients with ulcerative colitis compared to healthy controls. And then a study of patients with active ulcerative colitis and Crohn's disease versus inactive ulcerative colitis and Crohn's disease and healthy controls showed that there was much higher net concentration in the blood of patients with active disease compared to those with inactive disease and healthy controls. So a third explanation for the possible link between IBD and bronchiectasis is that the gut and lung microbiomes are known to be linked, and dysbiosis of the microbiome is linked to disease severity in both inflammatory bowel disease and bronchiectasis, meaning that this interplay between neutrophilic inflammation and bacteria could well also be at play in inflammatory bowel disease associated bronchiectasis. And then finally, eosinophilic inflammation is thought to play a role particularly in ulcerative colitis associated bronchiectasis. And again, we can see two studies here. One study looked at induced sputum in patients with ulcerative colitis compared to controls, and showed that patients with ulcerative colitis had a far higher percentage of eosinophils in their induced sputum compared to controls. And they also had more obstructive lung function compared to controls. And then another small study showed that patients with ulcerative colitis who had pulmonary involvement had higher fraction of exhaled nitric oxide compared to patients with ulcerative colitis without pulmonary disease, and also compared to healthy controls. So multiple possible explanations for the pathophysiology, but particularly the link with eosinophilia is interesting, as we know that in bronchiectasis without inflammatory bowel disease, inhaled corticosteroids are not recommended due to their link with infection and also their link with increased mortality. However, in IBD-associated bronchiectasis, the ERS guidelines don't comment on it, but the BTS guidelines suggest considering a trial of inhaled or oral steroids in patients with bronchiectasis and inflammatory bowel disease. And while this is biologically plausible, there's currently quite a relatively small amount of evidence to demonstrate symptomatic benefit. But this is one study which included 17 patients with bronchiectasis related to inflammatory bowel disease, and found that a significant number of patients reported improved symptoms after receiving both inhaled and oral corticosteroid therapy. So my conclusions from this case were that inflammatory bowel disease associated bronchiectasis is certainly an inflammatory endotype, and this inflammatory endotype marks a patient group who may respond to inhaled corticosteroids. But there remain questions about clarifying the exact pathophysiology of inflammatory bowel disease associated bronchiectasis, and also probably further research is needed to cement how effective inhaled corticosteroids are in this group.
Thanks, Emma. I often hear from people that that you're more likely to have a negative sputum culture in someone with inflammatory bowel disease compared to some of the other types of bronchiectasis. Is that your experience, that they're more likely to be sort of sterile patients, and therefore there's more likely to be a heavier inflammatory component compared to an infectious component? Or
I think that not actually my personal experience. No, I would say, however, you can see why that could be the case, given that it is a predominantly inflammatory endotype. So maybe the chicken and egg with infection and inflammation doesn't apply quite as much in IBD. Perhaps it's due to sort of systemic consequences of inflammation. So
yeah. And back in the day, I did my PhD on pheno in bronchiectasis, and I did longitudinal studies of people where I followed them up for a long time, and many people, pheno did not track how they were feeling, exacerbations and that sort of thing. But I did have someone in my study who had ulcerative colitis, and the pheno tracked perfectly how he said he was feeling, and he was treated with steroid. I just wondered if you think pheno could become a good marker for who we do and don't need to treat with steroids and bronchiectasis, and if maybe we should be measuring it more. So I realised my camera's off. I'll put it back on so you can see I'm smiling while I'm saying it.
I mean, I would say yes. I thought it was interesting that this lady wasn't eosinophilic and she didn't respond to steroids. So perhaps even within IBD or ulcerative colitis associated, there are an eosinophilic group who are responsible for that benefit that's seen. I don't know what other people would think.
And do you think it's all one or another? Do you think people have to be eosinophilic or neutrophilic, or you know, is there a mix of different inflammation going on that could flare up at different times? Or I don't think we know the answers, but
well, I don't know. I suspect they're overlapping. I suspect there are overlapping endotypes. The eosinophilic patients maybe are prone to eosinophilia, but potentially are also can get neutrophilic inflammation. But again, I'd be interested in other people's thoughts on that.
Chat's gone very quiet.
Yeah, maybe we have a raised hand. Andrew, please.
Sorry,
Hi.
Hi, morning or afternoon. I was slightly struck by how localized it was, just in the right lower lobe. And my experience of IBD-associated bronchiectasis is a bit more diffuse than that. And whether you'd gone down the route of looking at things like aspiration, given that they've got a gut history.
I agree, actually. I thought I would probably, I know everyone initially said that they would go for bronchoscopy, and I kind of agree. I think that the very localized area of bronchitis probably did fit with an area of infection. She didn't have symptoms of reflux, but I don't think that was fully, she didn't have any further investigations to test for that. Or she had, I think, been treated. Yeah, no, she didn't have symptoms associated with reflux, but yes, that probably could have been explored further.
Yeah, I treated a very similar case with right middle lobe atelectasis after IBD bronchiectasis, and he actually had anti-neutrophil cytoplasmic antibodies. So we were concerned that we're looking at vasculitis actually, but it did turn out to have, well, he didn't have any evidence of vasculitis other than ANCA, which can be a part of inflammatory bowel disease. So so we did end up treating like ANCA, like IBD associated bronchiectasis. Sometimes inhaled corticosteroids are just not enough, and you would have to treat with systemic low dose corticosteroids. So I would trial inhaled corticosteroids, but if it's not sufficient, then would go to systemic steroids.
I think based on the radiology, the inhaled steroids are not going to get to where they need to be based on the collapse of the right lower lobe now. So you would have to give systemic steroids.
They're considering referring for surgical, I think surgical intervention being considered as the next step as well. Should I move on to the third case? Or...
Yeah, thanks.
Okay, so case 3 was an 87-year-old man with a background of pulmonary tuberculosis in 1962, a diagnosis of asthma, and previous ABPA in 2005, which was successfully treated with steroids. He also had a history of reflux, chronic kidney disease stage 3, and again, never smoked, no occupational or environmental exposures. He was on high-dose inhaled corticosteroid with a reliever inhaler and PPI, his reflux. And he presented in 2022 with a few months history of large volume purulent sputum on a daily basis. He also felt more breathless and wheezy, and in particular was struggling on walking up hills. He had pulmonary function tests which showed an obstructive pulmonary function, and he had 3 sputum cultures positive for Pseudomonas aeruginosa. His bloods showed significant eosinophilia with a raised total IgE and raised specific IgE and IgG to Aspergillus. Other bloods were normal apart from his known chronic kidney disease, and in particular vasculitis screen was negative. And this is his CT scan, which showed bronchiectasis affecting particularly the lower lobes with a lot of mucus plugging, and there's some mucus plugging and bronchial wall thickening, as well as some cystic disease in areas. And so in terms of next steps in this man with Pseudomonas aeruginosa, but also serological ABPA, I'd be interested to know what people think about which one we would treat first, or both at the same time.
The answer to everything so far seems to have been everything at the same time. Oh, we have a vote for C. Someone here saying they'll go with ABPA first. Amelia, do you want to give your rationale for why you'd go for ABPA first, to put you on the spot?
Hello, everyone.
Hi.
Hi. Hello. Now, we'll probably go with the ABPA because probably it's easier to treat compared to the Pseudomonas. It's a long-standing Pseudomonas infection. It would take probably months to have some sensible benefit from the Pseudomonas. And by my description, it looked like the patient looked like more inflammatory than infective. So I could be biased, but I could probably go with ABPA first. And then if there is no benefit, I will consider treating the Pseudomonas.
Thank you. Emma, do you want to?
Yeah,
I thought you did.
So he started oral ciprofloxacin, but very quickly, as in within a week or two, it became clear that he remained symptomatic, very, very symptomatic. So quite quickly he was, we didn't proceed further down the antibiotic route and instead switched to high-dose prednisolone followed by a tapering course over several weeks. And he had an almost instantaneous, very significant improvement in his symptoms. However, unfortunately, after stopping the steroids, very quickly his symptoms recurred. And he continued to grow the Pseudomonas like growth, but his ABPA serology, which I think had dipped, then began to rise again. And so we discussed with him referral for biological therapies to spare steroids for his ABPA, but he refused. So currently he's maintained on long-term low-dose oral steroids and he feels fantastic. I think probably we'll have to discuss other options again in the future. So I suppose moving on to talk a little bit about ABPA diagnosis and management. As I'm sure you all know, IBP is diagnosed via the Isham criteria, which this man met all of. He had a total IgE over 1,000, positive specific Aspergillus IgE, raised Aspergillus IgG, eosinophilia, and radiological features consistent with active ABPA. And his treatment also was carried out according to current guidelines, which suggest a tapering course of corticosteroids. Itraconazole was considered as a steroid-sparing agent for him. I think there were concerns surrounding his renal function, and so he was not tried on itraconazole, so they moved directly to thinking about biological therapies. And then just to talk a little bit about how Aspergillus contributes to the sort of eosinophilic bronchiectasis. The mainstay of treatment, so in addition to itraconazole and corticosteroids, there are multiple new anti-inflammatory therapies in development for ABPA. So Aspergillus triggers Th2 mediated inflammation via epithelial and dendritic cells. It causes Th2 cells to release interleukin-5, which then results in eosinophil activation. And it also causes B cells to produce IgE, which again leads to mast cell degranulation and increased eosinophilic inflammation. And therapies have developed targeting both aspects of this cascade. Mepolizumab blocks interleukin-5, while omalizumab blocks IgE, both with the aim of preventing this downstream cascade of eosinophilic inflammation. And as you can see, there are multiple different other treatments targeting different aspects of the pathway. And evidence shows that these drugs are effective, and this is just one example of a recent systematic review and meta-analysis showing that omalizumab effectively reduces exacerbations, reduces oral corticosteroid use, and improves lung function in patients with ABPA. However, while ABPA is one cause of eosinophilia in bronchiectasis, it's now being increasingly recognised that even in the absence of known comorbidities such as asthma and ABPA, there is an eosinophilic bronchiectasis endotype. In a European multi-cohort study conducted by Amelia, which excluded patients with asthma and ABPA, but found that up to 22% of bronchiectasis patients were still eosinophilic, both in their sputum and in their blood. And the elevated eosinophils were associated with Streptococcus and Pseudomonas infection, and also with shorter time to first exacerbation. Similarly, a very recent multi-centre observational study from the Spanish Bronchiectasis Registry, which also excluded patients with asthma and ABPA, showed a U-shaped relationship between eosinophilia and bronchiectasis severity, where patients with very low eosinophils and very high eosinophils had worse outcomes. However, they also showed that treatment with inhaled corticosteroids, you can see in the second graph here, led to reduced exacerbations and hospitalizations in patients with high eosinophils, but didn't have an effect in other groups. And this also links to another previous study where the authors retrospectively looked at 3 randomized controlled trials of inhaled corticosteroids in bronchiectasis, which hadn't shown a treatment benefit in non-selected bronchiectasis patients. But when patients were retrospectively stratified by eosinophil count, those with eosinophilia over 4% had actually experienced a treatment benefit in terms of reduced exacerbations and hospitalizations, whereas this benefit was not seen in patients who are non-eosinophilic. So my conclusions from this case were the eosinophilic bronchiectasis is an inflammatory endotype characterized by Th2 inflammation. And in the cases of asthma and ABPA, there are treatments targeting the Th2 response, particularly anti-inflammatory treatments, are already being used. However, interesting to see the role of anti-Th2 treatments in patients with eosinophilic bronchiectasis without an unknown underlying conditions such as asthma or ABPA. And then just my conclusions that I drew from all these cases were that the most appropriate treatment approach in bronchiectasis is frequently determined by the inflammatory endotype that drives the disease. And as we saw in a couple of these cases, decisions may be complicated by overlapping endotypes, but that promising anti-inflammatory therapies are on the horizon, both for neutrophilic and for eosinophilic bronchiectasis. That's finished. Thank you.
Thank you, Emma. That was really brilliant. 3 really interesting cases, and I think really highlighting the importance of thinking about inflammation in bronchiectasis, and also the options available for treating it and how difficult it can be. Has anyone got any comments or questions for me, Emma, Mikhail?
Yeah, maybe I can just add that we really need to focus on differentiating the endotype of eosinophilic bronchiectasis from asthma, because there's such a large overlap, and we really need to see if that. So my personal opinion is that the phenotype of eosinophilic bronchiectasis does exist apart from asthma, but it still needs to be proven. So and this obviously would make the justification for both inhaled corticosteroids and biologic therapy, Th2 targeted therapy.
It's a really difficult thing to do, isn't it? Define. I guess playing devil's advocate, how much do we need to? Because if you're going to treat in the same way,
Yeah,
then does it matter to an extent what the label is or isn't? I'm not sure I believe that. I'm just saying it to be controversial. But yeah, I mean, if you're going to give an inhaled corticosteroid, then does it matter if it was asthma or non-asthmatic eosinophilic disease if it works? I think it probably does matter.
Yeah, I think for inhaled corticosteroids, it's important, but it will be even more important if we go and give costly therapies and need to persuade payers to fund that. So it will be really important to make that distinction.
Yeah, and yeah, biologics and getting things funded. Okay. Awesome. Does anyone have in the audience anyone have any experience of treating their patients with biologics, or anyone successfully off-label managed to do that?
I think that Stefano's group is collecting the evidence and collecting the cases of people with bronchiectasis treated with biologics. I have one case where several times methacholine was negative, and the patient had eosinophilic bronchiectasis, and she's responding to anti-IL-5 receptor. But so that's one unique case.
Yeah,
probably more.
It probably depends what country you're in and things as well as to what you can do.
I've treated CF patients with ABPA with Zola, but not a non-CF bronchiectasis. And well, I've treated quite a few actually. And it's a bit of a mixed bag of response, I would say.
Do we still need good biomarkers to figure out who's going to respond and who's not?
So I see that the last slide is on, and I want to thank Emma and Amelia for a great presentation and discussion. And I want to focus the next series, the webinars in this series, and the next one is the evidence-based and practical aspects of stable bronchiectasis by Andrea Gromega from Milan and Peter Hominy from Belgium. And there's more to come, so please join us for the next webinars. And thanks, everyone.
Thank you.